Hello, everybody, and welcome to this episode of Infection Control Matters. And today we're going to be talking about surgical site infection. And my guest is Dr. Gabriel Birgand, who is a clinical coordinator for EUCIC. And I'll get him to explain what that is at the moment. But he works in infection prevention as national coordinator for surveillance in long-term care in France, but he's based in Nantes. Gabriel, thank you very much for agreeing to speak to me.
It's my pleasure. Thank you for the opportunity.
I got out of an IPS newsletter recently that EUCIC had done a presentation on surgical site infections. So could you tell us a little bit about EUCIC and then where this presentation came from, please?
Yes, so EUCIC is a committee part of ESCMID, the European Society of Clinical Microbiology and Infectious Disease. And the aim is to provide training, guidelines, and some insight into infection control for a wide range of people across Europe, and even broader, widely, as EUCIC is now global, and so we're trying to fit a lot of different stuff, all included in a web page you can check if you want online, and you will find all the training courses. So there is modules with different topics and across Europe, and led by specialists in the field. So if I take an example, you will find a module on surveillance for infection. You will find a module on implementation science for infection control in Zurich, behavioral science in Malta, and so on. So a lot of different activities. And of course, if you want to contribute, feel free to contact us. Everybody is welcome, and every contribution is welcome as well.
Thank you. We'll add how to contact you in the blurb that goes with the podcast, so that's fine. So what's the EUCIC interest in surgical site infection that led to this presentation, which is a review of the latest papers relating to surgical site infection, isn't it?
Yes. So what we're trying to do is to provide to IPC colleagues a flavor of what has been published recently in different areas. And this time it was on surgical site infections. Mostly because it's my research area and it's easier for me to do this review, but we're trying to do it pretty frequently. The next one will probably be on AMR in healthcare setting, and with one idea, which is to make one slide per article, so no more than one slide, provided to people on PowerPoint. To give them the ability to change, all what they want and change the slides, do other presentation with the support already formatted and provided online. So there is all these slides on the EUCIC webpage. So you will find some materials there, and more will come, of course. So as it is time consuming, as you can imagine, we're trying to do it as frequent as we can, but it's yes, we'll provide more material soon on different other topics than surgical site infections.
So can we talk about the key themes that you discovered then as part of the review of the literature for this? Because it's a nice flow through in the presentation, which with your permission we will make available to people, but I know it's on the website as well, but we can highlight people to it. One of the first things that I'd spotted was the epidemiology and burden of surgical site infection, because it's still a cause of many adverse events, despite the fact we have reasonable evidence for a number of different interventions that we possibly don't implement reliably. Why do you think that surgical site infection is still such a major problem for us?
I think there is a lot of different reasons, I guess. So the first one is the evolution of techniques and so on that can lead to a decrease of adverse events, of course. But when we're not, managing these techniques pretty well, there is also possible adverse events that can appear. A second potentially effect is the evolution of the case mix. So patients are not potentially not the same now as they were a few years ago. But if you look at trends, to be honest, the trends are pretty decreasing since 20 years ago. The key point is that we are now reaching a stable, rate without decrease.
Yes.
And sometimes, and it's my current perception, I believe that we are even increasing for complication following surgeries. The post-COVID phase, I think, is not very positive in terms of quality and safety in surgery. So if the 20 years, I think we had a decrease, a stable phase, I think, in recent years, potentially due to the fact that the technical aspects are pretty well known now in terms of prevention of infection. But the key point is about implementing them, on the ground.
Yes.
It's true for surgical site infection, but it's true for all other
All
activities.
infections. Yes, it is. Absolutely.
So the implementation, I think, is also a key point. And I think to solve this problem, one potential perspective is but we all acknowledge that is to get into social science and human behavior, to try to address, the gap between the technical rules and their implementation on the ground. So what I think is more, I would not say interesting, but is threatening me is about the rise, the recent rise as a post-COVID rise of surgical site infection. And potentially, I think it's probably the case for other type of complications.
Yeah.
So that's why I think we need to address, to go back to the ground, to speak to professionals and try to improve, to improve practices, taking into account, of course, all the constraints we have in terms of resources, in terms of fatigue, and so on.
I mean, looking at resources, surveillance has always been pretty labor intensive. But with the advent of AI and imaging, there is a potential to maybe save time and give us at least reasonable information. You have looked at some papers on that. Could you summarize those and tell me what your thoughts are on the use of AI and other technologies in surveillance?
Yes, so it's interesting because according to periods, you have some topics, addressed in the literature, and it's there is a variability according to periods. So now I found a couple of paper on AI. So one was published in Nature Digital Medicine using a picture from wounds to try to identify surgical site infection, which is not a new concept. I remember a paper published more than 10 years ago already giving this concept and trying to address this point. What is interesting in this paper is the fact that there is a reduction of resources, so estimated to around 80% of reduction in staff time, which is something pretty interesting. And a second paper, which was more a confirmation of a model of AI system called Periscope, published in the Lancet Regional Health Europe, was to show that we can, just after the procedure, with the analysis of all recorded information data, try to predict with a pretty accurate model and estimation the possibility of complication after 1 hour after the procedure for the 30 days following the procedure. So I think AI was promising 10 years ago. It's becoming more concrete now, definitely.
Yes.
And I think we'll have option on the ground pretty soon. And I guess, of course. I hope.
Yeah.
Sorry.
I mean, the thought of being able to predict complications within an hour of surgery, you could actually detect something systematically going wrong in an organization if the same sort of thing is popping up, rather than waiting for all the surgical site infections to maybe appear, or if, of course, patients have gone home, possibly not even appearing. So that's got a lot of potential for early intervention in a system problem, I think.
Yeah, definitely. Rapid identification, rapid alert is also potentially something interesting with the use of these tools. Yes,
fascinating.
true.
Yeah. The next topic area I picked up on was the patient's own microbiome and how that can change throughout life, through age and BMI, etc. So what are your feelings about the patient's own microbiome? Because we tend to just view people as that's a person and this is what we need to do, rather than individualizing it, unless you're screening for something like Staph aureus.
Yes, so there was also other paper talking about decolonization that we'll speak about that later, I think. But two paper, one from the Swiss colleagues, so they are very productive with the Swiss NOSO, network, yes. Surveillance network. Amazing work they are doing, with different paper recently published. This one was in British Journal of Surgery, trying to analyze more than 500,000 patients data and trying to see what was a link between the preoperative wound swabs with microbiological results and what happened in surgical site infection, and trying to highlight what were associated variables, like age, BMI, duration of surgery, and they found a sort of patterns of patients that can lead to predict the type of microorganism you can get in surgical site infection. And they even developed an app, but unfortunately, I struggled to access to this app. It's a Google app. But if you are feeding the app with patient information, it can give you, the predictive value for Staph aureus, Enterobacteriales, and so on. So the concept is very interesting, I think. And another article, second one from Science, is also very interesting. From my point of view, which was also to match the preoperative microbiome sampling with the postoperative infection results, and they found two important, I think, results. The first one is that around 86% of bugs come from the patients. Solving the question of endogenous versus exogenous aspect of surgical site infection, which we still don't know in this, and it's different according to type of surgery, but here it was spine surgery, clean surgery. So for clean surgery, I think SSI is from 80 to 90% endogenous. And second point was about antibiotic prophylaxis mismatch, which was estimated to around 60%.
Yes.
Which is pretty high. So with the conclusion that personalized antibiotic prophylaxis would be the next step, if we want to improve this.
Then you've got to do some pretty comprehensive screening, haven't you? But I thought this was a fascinating paper because, for me, this is clean surgery with you putting metal in, and so therefore a close to 7% infection rate is pretty high compared with, say, a joint replacement. But it would undoubtedly, presumably, be done in ultra clean theatre if that is the habit, even though there is debate about ultra clean theatre. And so not having the prophylaxis right, but this is actually doing metagenomic analysis of skin, nasal, and rectal swabs. So this isn't just sending a swab to the lab and seeing if you're growing a Staph aureus. This is much more complex. So then the cost effectiveness of doing all this would have to come into play. But I would think this is going to be expensive surgery, and the length of stay, etc., may be quite extensive post-op. So it may turn out to be a little bit more cost effective to do this.
No, definitely, and it's not. There is other paper published recently, trying to address this point for personalized medicine, of course, but also to try to estimate the endogenous versus exogenous part in clean surgery. And I remember a paper, finding 10 strains from surgical site infection and from the patient, and trying to also sample the air from the operating room and matching one strain among the 10 with one found in the air and so on, and with the final result, then 10% is from the environment and not from the patient. So it's we need to go further on it. Very interesting study.
It is interesting. The question I always ask myself is, when does exogenous become endogenous? because you could acquire an organism today and tomorrow it's endogenous. So I struggle with that one because there's no true definition.
No, that's true. And
we all acquire organisms from somewhere. Every organism we acquire is exogenous.
But during surgery, and
during surgery, no. Yeah, it depends. You see, we used to say don't admit people for several days before surgery because your microbiome may change. You'll pick up all the hospital-acquired organisms. So if you are doing this metagenomic, you would do it as outpatients and bring them in on the day of surgery rather than bring them in a week before and then wait for the results, by which time the home microbiome may not be the one that they came in with. So that's an interesting point as well. Can we go on then to patient or preventative interventions and decolonization? Because there's a debate has been going on about the chlorhexidine bathing, etc. Although Susan Huang's shown critical care to be extremely effective, and nasal povidone iodine has come along as well. And then we've got these randomized trials on skin antiseptics. So, what are your findings in this particular area?
Yes, so there was, I think, 4 or 5 papers on the same topic. It was not exactly on decolonization, but it was also on skin prep. So there was first one from CMI, in very specific surgery, which is pancreatic surgery, trying to see if bathing a patient with chlorhexidine 2% was effective, and it seems to be the case in this RCT published on 600 patients included. So one potential perspective is to use this thing for pancreatic. Another one was on cardiac surgery from French colleagues. So this is the same team as the one who published, the Lancet paper on chlorhexidine for CLEPSI or catheter, and finding, an advantage of chlorhexidine for the skin prep before insertion of catheter, central venous catheter. Mm-hmm. But here for cardiac surgery, it seems to not be the case. So chlorhexidine alcohol compared to polyvidone iodine, no difference. And it's also referencing, the WHO guidelines published in 2018, recommending the use of chlorhexidine, for a clean surgery, for surgery overall, which generated a huge controversy, as you remember. So this is potentially the reason why we have such an amount of paper on this topic now. It's as a result of the RCT, launch just after the release of WHO guidelines. And 2 other papers on this topic. So a British Journal Surgery paper on olanexidine, which is a new, for me, at least it is a new compound component for skin antisepsis. With an equal result in terms of effectiveness in comparison to chlorhexidine alcohol. And finally, Andreas Wilmer, of course, with the JAMA article, RCT, comparing chlorhexidine gluconate alcohol versus polyvidone iodine for cardiac or abdominal surgery. No effect. They were both equal. Non-inferiority of polyvidone in comparison to chlorhexidine. So I think if we take all these articles, the summary would be to say, okay, you can use polyvidone iodine alcohol or chlorhexidine alcohol when compatible with your procedure to do skin prep.
Yes, I think the key thing is making sure that whatever you're using is in with alcohol as well, and not in an aqueous format. But also making sure you give enough time for it to dry, so that you don't start diathermy with a pool of alcohol underneath somebody. That's been an issue here in the past.
Definitely.
The next group, stewardship, prophylactic antibiotics. People have been overusing them potentially. What were your findings on that one?
I guess you are speaking about the cardiac and portable electronic device and antibiotic prophylaxis. Yeah. So I choose this paper because for me, there is pretty poor data on the complication following this type of procedure because it's very rare events, and trying to estimate these events is pretty difficult. And so it's it's a population-based cohort performed by colleagues in Australia. So they try to address this point using more than a bit less, sorry, than 50,000 implantations, and they found that 40% of implantation were followed by prophylactic antibiotic prescription, which is pretty high, I think, and with on the other hand, with a pretty low level of complication at the end. So less than 1%, 0.8% of complex SSI at 1 year following the implementation of the device. So my idea here was more than to highlight the percentage of antibiotic prescription in the 48 hours following the implantation.
Yeah.
And I think for me, it's pretty high, and with a lot of potential antibiotic use that can be avoided, I think, in this for this example.
Yeah, couldn't agree more. Can we then move on now to hands and gloving? There was a couple of papers you've highlighted on contamination of gloves, double gloves, indicator gloves.
2 papers on gloves in surgery. So we know that there is a incident, there is glove breaches. In surgery, it's well known, of course. But one paper published in Journal of Hospital Infection tried to estimate this event, and they estimated it to around 10%, whatever the type of procedure, and more than 50% in orthopedic procedures. And so it's pretty high, and with a potential, of course, increase of adverse event for the surgeons themselves, but also for the patient in terms of contamination. So very interesting, with a potential solution through indicator system gloves. So when you have 2 layers, glove with 2 layers and a sort of color between the 2 layers, when there is a breach, it can be seen by the surgeon, and they can change their glove when the thesis. So it's an interesting one, and linked to this paper, second one from Infection Control Hospital Epidemiology, showing the level of contamination, bacterial contamination following a breach in the gloves, and also interesting, I think. So after reading this 2 papers, I spoke to my colleagues saying, okay, we should have a look at the proper use of gloves during surgery, and how surgeons and people on the site are turning their gloves, because I think in orthopedic surgery can play a role in terms of contamination of the wound.
Especially as it's common skin bacteria that actually cause significant issues in orthopedic surgery that maybe do not manifest for a couple of years. So that's an issue as well. Can we pop on now to look at a thorny issue of bacterial air contamination, firstly during prep of sterile goods, and then door openings, which is always a thorny issue in the operating room?
Yes, so 3 papers on that topic. So first one, trying to compare 5% versus 2% in the operating room during the preparation of goods, preoperative preparation, and trying to assess the level of bacterial contamination in the air. So they've put blood agar, and plates on goods, and comparing 5 versus 2. And they, of course, found a difference in terms of colony forming units, but also a percentage of plates contaminated. So for 5%, to give you an idea, it was 48% of contamination of plates, in comparison to 36% for 2%. It's pretty pragmatic to say the less you are in the operating room during this stage of preparation of all instruments, the better it is to not have turbulence, to not generate particles and contaminate all instruments. So this is the first one. And second one, which is a systematic review of paper on the number of door openings. And 8 studies were included in this review from people in Netherlands, published in BJS Open. Then found at the end a very low level of evidence, because it's very I participated to this type of study because one of the 8 is from me. So I can say that I think it's pretty rough studies, observational, without any control and so on. But what is interesting, they concluded that if you are increasing the frequency of door opening by 35, so 35 additional door opening per hour per surgery, you can cause 1 additional SSI per patient. You see what I mean? So
it's non-significant, isn't it? It's significant that, yeah.
It's an estimation, of course, based on this very limited data, but there is a trend. When more you are opening doors, more you have surgical site infection. So there is still studies to do on that, of course. And finally, one article published in New England Journal of Medicine Evidence trying to put low-cost air purifiers in operating room for orthopedic surgeries. So there was operating room with, so all operating rooms, were with this type of device, purifying air, but one was switch on in some operating rooms, and for other the device was off. And they compared the SSI rates, and they found no difference in terms of. So it was not exactly SSI rates; it was a proxy of SSI using antibiotic use and so on. But they never found a significant difference when the device was switched off in comparison to switch on.
Yeah.
So interesting studies as well.
You've got a paper on triclosan sutures, I noticed.
Yes, it's just an update of a systematic review. Nothing very new here. Still moderate certainty of the reduction of SSI using this type of sutures. So still something to prove.
And then perioperative oxygen. You've got a paper on that as well.
Again, so it's coming from the WHO guidelines. As you remember, there was one guidelines from WHO saying that we needed to keep the oxygenation pretty high following the procedure during 6 hours, and there was a huge controversy from the anesthetist world following this recommendation because it's pretty difficult to do, and some anesthetists were saying that there was potential complication. So the conclusion of this BJA article was to say, okay, nothing in favor, nothing in disfavor of high oxygenation following the surgery. Nothing very significant.
Nothing that might make the risk of other complications worthwhile. No, okay. And last couple on wound models and wounds, aren't they? And negative pressure and blue light. Just summarize those for me.
Yes, for negative pressure is still a question tag. Should we use negative pressure wound therapy for patients? And there is some guidelines, including the US guidelines, saying that it could be interesting in some subpopulation like high-risk patient, in surgery, in cardiac surgery, for example. Here, it's an open-label multi-center RCT in 28 UK NHS trusts. So pretty strong study published in Lancet. No difference when using negative pressure, whatever the type of procedures. They included a lot of different procedures from clean to dirty procedures. Nothing very interesting.
No. And it's likely to be a reasonably costly intervention to get no change. So okay. And the blue light?
Yeah, blue light, model, just for fun. Just for fun, it's Journal of Infectious Disease paper showing that potentially the addition of antimicrobial blue light, it's a porcine model, animal model, but antimicrobial blue light can improve, the reduction of contamination following surgery, and combined or not with antimicrobials, photosensitizers, and so on. So potentially a perspective, but not very soon, I think.
Not soon. Okay. Well, thank you very much, Gabriel. It's a very nice succinct and has a nice flow to it, this presentation. Tell me, I mean, you've already indicated that you're going down the route of looking at the indicator gloves in your organization. You know, are there some low-hanging fruit here that people could look at already in advance of surgical guidelines changing? Is there anything that is likely to change practice?
You mean according to all this literature and so on?
Yeah.
I think there was guidelines released soon from US. I'm not fully sure we'll have guidelines in SSI released, you know, in the coming 2 or 3 years. So we'll need,
I don't think so.
To wait a bit.
Yeah.
I think the most and as you've seen, you know, for WHO, it was a huge work. They've done a lot of different meta-analysis. So I'm not seeing guidelines released at an international level by WHO soon, but maybe I'm wrong. Mm-hmm. And the same for US because they published it, I think 2 years ago. So I would not see, you know, a huge evolution in terms of guidelines now. And in the meantime, of course, this type of literature review also provide, you know, some insight into some topics, and we are not, you know, waiting a recommendation to change practices. The evidence is coming from the science and not always a recommendation.
Okay, well, thank you very much for your time, and fantastic work from EUCIC. Look forward to seeing more presentations appearing, and really appreciate you doing this for me. Thank you.
Oh, thanks to you.